Good morning, everyone. Sorry for the technical delays there. And we'll just remove the ladder. Welcome to this first session at the ERS. Thank you for getting yourselves up early and coming to hear about the sense of smell and how to manage issues with smell and taste disorders. So my name's Philpott, and I've run a smell and taste clinic for best part of the last 8 years. So I'll take you through my pearls of wisdom on how I suggest we might approach this. My disclosure is that I'm a trustee of Fifth Sense, which is a charity which represents patients with smell and taste disorders. There we are. Right, okay, good. I'll try again. So, over the course of this session, I'll do a little bit of scene setting, think about the history of a patient who presents with an olfactory disorder, and think about a structured approach to managing these patients, both thinking about quantitative losses and qualitative disturbances, and also some conservative management and coping strategies, and thinking a little bit about the future and what things may be coming our way as future treatment options. The comedy of errors, this. So, hopefully the slide will come up in a moment. So, there we are. Okay. So, there are some surveys that have been done around the prevalence of smell and taste disorders in the community. So, going back, the National Geographic readership was polled back in the 80s. They were sent little scratch and sniff cards out with the magazine. And the return they got on that, which was in the order of several million, was that about 1.2% were rated as anosmic. More recently, doing all sorts of things here. More recently in Spain, there was a newspaper survey. They came out with slightly lower figures for anosmia, but actually when they looked at hyposmia, okay, thank you, then they found that actually there was quite a large number that were affected by some loss of smell, even if it wasn't complete loss. And what they found in that study was that risk factors for poor olfactory function were being male, low educational level, previous head trauma, maybe not surprising, pregnancy and age. And then separately, the German-speaking ENT group in 2004 did a survey of ENT practitioners and their hospitals in their group. And we'll go on to the next slide, that one. And what they found was that actually looking at what were the key causes of smell disorders, that this pie here, for those who don't speak German, was essentially the sinonasal group. If you add in other sort of causes of nasal obstruction, then actually these two parts of the pie were adding up to about 70-odd%, with post-viral coming next, and then you've got the idiopathic group and the head trauma. So if you look at it in a more global perspective, actually the sinonasal group is by far and away the biggest group out here. And I was just about to point to, oh, here we are. So now you see it, now you don't. So this was an online survey that was done, I think through Google Adverts actually. And again, these were people sort of self-reporting, and you can see that the sinonasal group came in top here. And actually what they did in this paper was they actually sort of compared themselves to previous things, and you can see, you know, the sort of range of spread, but clearly the kind of trend is the same on all of these surveys. And if we think about that in context to other sensory losses, and we look at the UK at our Royal National Institute, so the one for the blind, those with complete sight loss are about 3%, and those with profound deafness are about 1%. So if we're thinking at 1% of people who are anosmic, actually we have an equivalent sensory loss, and actually the proportion of interest that's devoted to this is much smaller. Okay, so taking your history. The key thing obviously at the beginning of the history really is the onset and timing. Clearly that gives a large clue as to the sort of diagnosis you're going to be thinking of. The insidious onset is likely to represent someone with sinonasal disease, the timing specifically around a viral infection, post-viral loss, patients sort of noticing the loss of smell after a head injury, and there will be some patients who just really, there's a moment of realization that actually it's gone. Those are often the cases that turn out to be idiopathic. And it's really just asking them to think back, cast their minds back and think about events and trawl a little bit through what may be precipitating causes they haven't thought of. Maybe they were started on a new drug by their GP. Maybe there was actually some event, they had underwent a procedure that they hadn't really thought about before. So just really kind of thinking through the actual timing of when this happened. For some of these patients, it may not be them necessarily that thought about it the first time, but actually it was someone else saying, well, have you not smelt that in the food, or have you not noticed this smell that sort of, or you've set the kitchen on fire and burning smoke and they haven't picked it up. Clearly important to think about rhinological symptoms. Is this just anosmia in isolation, or are there other symptoms from the nose present? And do they describe qualitative disturbances? So we're thinking about parosmia, so does a good smell different or bad? And invariably parosmia tends to be an unpleasant sensation. So the smell of a rose smells like a rotten cabbage, for instance. And they may experience phantosmia, so they're imagining smells without a stimulus being present. Very occasionally, obviously, they may perceive a bad smell, and they may say there's a bad smell in my nose. And then you have to think a little bit about whether there may be some hidden rhinological disease. A fungal ball is often the most common example there that you may pick up on examination or investigation. A lot of people will come in talking about taste disturbance, and they'll say, well, I can't smell and taste. And one of the problems is with our language, certainly with English, is that we talk about taste, talk about tasting things, and actually in the general context we're thinking about flavour perception, we're not thinking about taste in the gustation medical sense. And a lot of people will get hung up about that, and you really have to sort of carefully pick through. And so I say things to them like, if you had a cup of tea and someone put a teaspoon of sugar in it, would you notice the difference? Would you notice the saltiness of a packet of crisps? Just simple questions to get their minds thinking about those key taste elements that they probably actually are able to pick up. And the reality is that for every 100 patients that I see with a true smell disorder, there's probably about one patient with a true gustatory disorder. Obviously, we mentioned about prior medical surgical history. There are a number of medical factors which we'll come on to which may be relevant. Drug history we mentioned. And also it's important to get their expectations. What are they hoping to get out of this consultation? Because inevitably, not everyone you will be able to give a treatment to, but you may well be able to give them some reassurance or give them some guidance, or just set their mind at rest that actually they've had this problem taken seriously. So we can break causes of olfactory disturbance into two key areas, like we do for hearing. We can talk about conductive causes, so mainly thinking about sinonasal disorders and other problems within the nose. And obviously things that we as ENT surgeons can do to unrest their sense of smell. And then we can think about the sensorineural group, which the two key ones will be the post-viral smell loss and the post-traumatic cases. And of course there are a number of smaller print causes, so neurological things, and I guess the key one here is Parkinson's disease. So 90% of people at the point of diagnosis of Parkinson's, which is a clinical diagnosis, made on their signs, their clinical signs, will have loss of sense of smell, complete loss of sense of smell. And the belief is that probably occurs up to about 5 years before the onset of their motor symptoms. And so in our clinic, we have a national study running called Predict Parkinson's Disease. So we'll actually recruit these patients to take part in that study. We don't know what the conversion rate is from cases that are considered idiopathic. The studies have been done to date probably suggest somewhere between about 2% and maybe 15% of those patients may go on to develop Parkinson's. Alzheimer's also has a tie-in with anosmia. And again, if there's any concerns about that, you could do a mini mental state examination. And if they haven't got any problems at that point, you can ask them to keep that in mind in the future. Tumours, obviously a consideration. They're a rare pickup, and we can come on to imaging shortly. And there may be occupational cases where there's been a toxic exposure to some hazardous chemical. And again, that will hopefully be relevant in the history, that you get a concept that they've been exposed to something and then suddenly that problem has arisen from that moment in time. So medical complaints, diabetes, because you can get diabetic neuropathy, so that's the possibility. Chronic renal failure. And occasionally you see cases of hypothyroidism that where they're not managed adequately, and hyposmia is a feature of that. And then some of these things, rarely so. Psychogenic cases, obviously, particularly with qualitative disturbances, they may sort of have issues like schizophrenia, where these are sort of part of that. And then from a perspective of a specialist clinic, about 1 in 5 patients that I see in that setting will be idiopathic after full investigation. And the other thing really in the history is thinking about the impact. Is there impairment of physical health because of malnutrition? Are they exposing themselves to domestic hazards? Is this affecting their work? Is there something they're doing? They're a chef, they're working with food, they're working with hazardous chemicals. Is it affecting their financial security in their profession? Is it affecting their social situation? And those are common things you'll encounter. As I mentioned, Fifth Sense is a charity that was set up in 2012, has now received registration with the Charitable Commission last year. And a few years ago we polled membership, which at the time was about 500 people. And what we found was that depression and anxiety were reported by almost 2/3 of sufferers. Just over a quarter had received some form of treatment in terms of antidepressants or counselling, and a further 25% had sought over-the-counter remedies. And of course the impact on eating is about 1/3 of people will just not eat because they lose interest, and about another third will actually gain weight because they go for the takeaway curry because it's spicy and they get some stimulus from it. And then about a third will sort of manage to kind of keep an even keel. So this was our survey. This was based on the olfactory disorders questionnaire, and you can see the sort of various responses here. And the biggest things, if we look down the bottom here, where they got the most agreement with the statement, was around experiences around food and drink, but also fear of danger from exposure to rotten food and hazardous chemicals, and feelings of anger and frustration, and also isolation, and that's a common one that comes out. The first time we did a public engagement event about 6 years ago for patients with smell and taste disorders, one of the key things that when people walked into the room that time as individual sufferers was this moment of realization that actually it wasn't just them, it was lots of people. And that's going back to those population surveys. A lot of these people think they're in isolation, it's only them, and they've been dismissed a lot of the time by family, by friends, and by medical professionals. Oh no, we've gone again. We're offline. Oh, there we go. Right, so give us got 1 minute here, the next investigation. So investigation really will be guided by your history, and I guess the key thing next is your examination. So important to have a careful examination of the nose. I'll use a 30-degree rigid endoscope, have a good look, particularly in the olfactory clefts. Are they clear? Is there edema there? Is there stenosis there? And just thinking about, is there any conductive factor which you might want to investigate further? There we go. Right, so endoscopic examination. And you may obviously have a clue to this already from the history you've taken, and this may confirm what you suspect. Imaging. So if you've seen something that is so for CRS, then a CT scan may be relevant. In certain cases of head injury, if you worry about associated trauma, you may find a CT scan useful. And then an MRI scan I would select for cases of head injury, which I'll come on to in a bit. I wouldn't do an MRI scan routinely for everybody. I certainly wouldn't do it for the post-viral cases unless you're not unsure of the diagnosis, because I think really that once you've got the history and you've examined the nose and seen that the nose otherwise looks fine, there's probably no value in additional imaging at that stage. For the idiopathic cases, it's really there to exclude the small possibilities of say rare things like an olfactory meningioma. And then you may, based on the history, or if you've got someone with no other apparent cause, want to do some blood tests to look for some of those medical issues that I mentioned before. And I guess the key thing then next is to go on to perform testing of their scents. So we use the sniffing sticks test, and this is a well-validated test in many countries now. Takes about 20 to 25 minutes to perform with a trained member of staff. There is a free piece of software which you can download from Thomas Hummel's website in Dresden, which can run the test for people taking it. It's got a little button there which switches it to your language and your cultural setting, which is great. It gives you 3 components. So it gives you a threshold component, so think of your depth of sense of smell, discrimination, and identification. Now, the key reason I like this as compared to some of the other tests which are available is because these 2 parts of the test are non-verbal. The problem with identification is it does rely on memory recall about naming an odour, and it also does rely a little bit on experience that they've been exposed to those odours previously. Whereas these 2 parts of the test, there's no need for that at all. It takes that out of the equation completely. So you get a good sort of sense of their olfactory performance from all these 3 components. And the printout you get looks like this. So this was actually me a few years ago when I had acute sinusitis. So you can see that my threshold was somewhat attenuated. I managed to get 11 out of 16 on discrimination. I identified 10 of the 16 odours correctly at the bottom there. And I guess, as with many things, this is obviously useful as a baseline as well to have for comparison if they come back after any treatment. On a few occasions, patients may be very fixated about flavour perception and be convinced that they can smell things orthonasally, so from the front of the nose, but they seem to have a perception that their retronasal olfaction is a problem. And therefore, you can do a test, and this was something that we validated as a group of over 7 countries a few years ago now. This is basically powders. You put them on the back of the tongue. It's an identification test, so they get 4 choices for each one. And it really replicates that sort of process of what they're doing when they're eating, so the retronasal olfaction. But obviously, if you are concerned that there is a true gustatory element to their problem, then this is the taste test kit, which you can buy from Burkhardt. It's the same company that produces sniffing sticks. And again, there's a bit of software which you can download which runs this. And it's very simple to do. You alternate between 2 sides of the tongue. For each of the 4 taste modalities, there are 4 concentrations. And I guess the key reason for doing this is because of this. This is from Richard Doty's handbook. And what you find is if you look at the complaints of people that walk into a smell and taste clinic and you look at the results of testing, what you'll see is that people are convinced they've got smell and taste problems. And of course, the reality is that true taste loss, as I mentioned before, is a very small proportion. These are the ones with only smell loss. And actually, some patients may well have no problem at all. They just perceive that there is a problem. And it may be that they're worse than they used to be, but from our perspective, they're still within the range of normality. So if I look at sort of the sort of typical pattern of patients that we see in a specialist clinic, you can see that we do get patients with sinonasal disease, although we try and sort of screen those to the main rhinology clinic. But a lot of idiopathic cases, and then the post-viral and post-traumatic cases are the next most numerous. So in terms of management, as I mentioned, I think the key thing really is once you've done your endoscopy and you've kind of got a clue as to is there a conductive or a non-conductive problem, that will help sort of start the process. You've done your smell testing and you can start thinking about prognosis and potential management options. I guess one of the myths is that there is no treatment to give to these patients unless they have CRS. And I think that's not entirely true. But one of the problems is this, is that although a lot of things have been tried and have been performed in studies, the number that have been done in double-blinded studies is very small, outside of these ones at the top. So a lot of these things have been sort of considered, but what we really need to do as a research community is get more trials underway to really say, do these things work, or are we just clutching at straws? If we think about sinonasal causes, then you can break those into non-inflammatory, so anatomical issues, or forms of rhinitis that are side effects of medications, or inflammatory causes, which really thinks about allergic rhinitis and CRS, or toxic rhinitis, and perhaps localized disease of the olfactory cleft. As I mentioned, CRS is very common, but one of the things that we found doing a qualitative research study interviewing patients with CRS was that the loss of sense of smell as a symptom within CRS was frequently dismissed by GPs, by medical practitioners. So these patients want to know that within the management of CRS, is their sense of smell being taken seriously? And so there are some things that you can do in order to try and optimize their sense of smell. This is a laryngeal atomizer, which I find particularly useful, especially in post-operative patients who've taken through sinus surgery, who have still got problematic, particularly polyp formation in the olfactory cleft, and you want to control that. I find this a particular problem when patients have had partial or middle turbinate resection previously. But you can train them to use this. Sometimes I'll get them to put some dye into the syringe and actually practice in front of me, and then I'll film the consequence of their spraying and play it back to them on the screen. And that'd be quite a useful educational tool to understand where they're actually sticking the tip of this and where they're spraying it to. So you can use sort of various steroid formulations. We tend to use sort of budesonide and get them to spray that in the olfactory cleft. And we'll come back to smell training as well. So this is what I mentioned. This is a sort of the problematic sort of patient who's sort of been ravaged by some previous sinus surgery, what I call the battlefield nose. They've had middle turbinate chomped out by a microdebrider previously, and they've got this very sort of scarred-looking olfactory cleft. And there may be sort of considerable variation in how well you can treat this. What I've seen over the years is that particularly patients with polyp disease, particularly fungal sinusitis, is that the polyps try and sort of form a neoturbinate, and it sort of essentially blocks the olfactory cleft. And that's where the targeting steroids really to that spot is quite useful. And of course, you do need to have some olfactory epithelium. This was a scan that someone sent to me from another continent asking if I could help them restore the sense of smell. As you can see, quite a radical procedure. There was a modified Lothrop being done. The septum was missing. The turbinates were mostly gone. And it's a pretty sad situation, really. I mean, this patient was told that their disease was well controlled and they could breathe better, but actually the one thing they wanted to be able to do was to smell better. And I guess the other key message is that if you have imaging is to look at it and look at it yourself and don't rely on the report. And I've time and time again seen reports that say something and you look at it yourself and think, well, I mean, this was a classic example. This was a scan where the radiologist had focused on a meningioma that was in the vertex somewhere that was barely visible and had not mentioned at all about the fact the nose was full of polyps. And this patient had been seen 10 years prior to me by a neurologist and told that there was nothing they could do for the loss of sense of smell. This was another one that was reported as, this was a fungal ball actually that turned out to be in this sinus that again was, the report said minimal mucosal thickening. So just have a look yourself at the scans. Sometimes actually the radiologist may well pick out something that you don't see, but look at both. Look at the report and have a think for yourself. So we think about sensory neural causes, then we can look at the key main groups. So in the post-viral group, do make sure you exclude CRS because some patients will focus on the smell loss, but actually when you dig down, actually for the last 6 months they've also had a runny nose and unblocked nose, but they've focused really on the smell loss as an issue. So for those patients, I generally sort of start them on some oral prednisolone and some topical steroids if they've not had that already. And you may well get some response to that, and if they do respond, adding in ginkgo biloba, where are we going again, may prove to be additionally beneficial. Beyond that, I do use oral theophylline sometimes in these patients. It's not easy to use, it requires blood monitoring, but the return rate I get from this is probably about 40%, so 4 out of 10 patients that try it will seem to get some improvement from it. Pentoxiflin was shown in a study from Thomas Hummel's group to potentially improve sense of smell. My experience with it has largely been disappointing. and we've gone. But if nothing else, and this group, smell training, which I'll come on to in subsequent slides, has probably the most benefit for any of these groups overall. In the post-traumatic group, I guess the key thing really is to look at the cause of the trauma, particularly if they've had facial trauma at the same time. I would always do an MRI scan to assess the level of damage. And if you catch them within 12 months, I certainly consider giving them some steroids. Again, there was a trial that was done in Taiwan where they included prednisolone, zinc, prednisolone and zinc, and placebo, and the prednisolone and zinc group appeared to get the greatest improvement. And in certain cases, if they're hyposmic, then I may consider sort of taking them through some of these options. If you've got a clear neurological cause, an MRI scan is useful, and then you need to refer on. If you've got a congenital case, so they've never been able to smell as far as you can tell, it's important to do an MRI scan to look, are the olfactory bulbs present? Because if they're missing, you can very quickly say, okay, well, you're actually missing part of the pathway. And very occasionally, you may find actually that these patients have, their sort of turbinates have grown into the septum, and actually they've got a conductive problem which may be retrievable. But on the whole, largely you'll find that it's the olfactory bulbs missing, which is the key problem. And therefore, you obviously need to sort of counsel these people accordingly. And then, in all other cases, if there's no clear cause, I would do an MRI scan, I'd do some blood tests to look for anything that we're missing. And then if normal, I would say, well, there is a possibility actually that you've had a virus, it was subclinical, you didn't notice the problem. And really, depending on the patient, depending on how old they are, depending on their medical comorbidities, I would talk to them about whether they want to try any options, given the knowledge that we don't know what the cause is and that we may slightly be second-guessing what we're doing. And so just give them the option. But again, counselling and, if nothing else, smell training. So just to give you a few examples, this was a patient of mine who decided to do a little drawing for me about her perception of her post-viral olfactory loss. So this was the size of the cold, and this was the size of the problem caused by the cold. And this sort of, this lasting effect for something that was only actually with her for a week and a half. So, as I mentioned before, it's the second most common cause of smell loss. Typically, these patients will describe a viral respiratory tract infection. Usual symptoms are present, but they're often recorded as more severe. And in quite a few patients, they will say that they've had this happen on previous occasions, but it's come back, but this time it hasn't come back. And what we suspect may be happening is that there's a sort of gradual deleterious effect of several viruses. It tends to be women more than men, and it tends to be a problem in middle age. And there are a number of viruses which have been found in various studies to be causative agents. What typically happens is that there's a reduction in ciliated olfactory receptor cells, and therefore there's a reduced area for detection of odor molecules. And when we think about the way olfaction works, parosmia is a key symptom in this because often what happens is they're missing part of the receptors. So if you imagine most things we smell as a mixture, they're therefore missing parts of the jigsaw, and what they smell is a distortion of what they should smell. So here's an example, a 57-year-old male with a 2.5-year history of anosmia, phantosmia and parosmia, who was referred on for another department, underwent an MRI scan which was normal. The patient already tried a steroid nasal spray and some zinc supplements, no perceived improvement. TDI score was 15 out of 48. Function anosmic. Olfactory disorders questionnaire was quite a high score, and the patient's already had depression and anxiety. So examination of the nose, there was a little bit of septal deviation, a little bit of polypoid deformation in the middle turbinate. The olfactory clefts were grossly clear. Patient wanted to avoid further steroids, so we talked about theophylline. I saw him then 3 months on, sort of after he'd started on this. TDI score had come up to 24.5. The qualitative disturbances have resolved, and the patient sort of carried on a little longer to try and see if they're getting further improvement. Okay, so we get an example of post-traumatic loss. So here there can be various mechanisms of injury. Classically, people talk about the sort of shearing of olfactory fibres, and I think when you look at the MRI scans, if you do them, what you find is that probably isn't always the case. Actually, often there may well be contracure injuries in the brain itself. One of the other theories is that actually, although the nerves aren't necessarily severed, is that there is edema and perhaps disruption of the blood supply around the olfactory nerves, and therefore it's an ischemic effect rather than a direct shearing effect. The other thing to think about, obviously, if they've had facial trauma, is have they deviated their septum? Have they got either a pre-existing sinusal disorder or even a secondary rhinosinusitis as a consequence of the injury? One of the key things to remember about this group is that perhaps if they've had multiple trauma, is at the time of the loss, there may have been an ITU, they may have been unconscious, and they won't really have thought about loss of smell until after they've got home. It's going to be something they think about further down the line. The other thing often I hear people say is that they say, I presume that the hospital food was that bad that I just couldn't taste it. So do actually go through and say, well, actually, no, I think we need to test your sense of smell and see what's going on. So yes, I would always get an MRI scan, really looking at whether there's evidence of sort of gliosis, particularly in the orbitofrontal cortex and around the olfactory bulbs. And again, do the endoscopy to make sure you're not missing anything which is an additive conductive component. So there's your typical sort of changes in the medial orbitofrontal cortex. You can see there as well. So really with these patients, the minimum I would recommend is to try and do some smell training and give them some prognostic advice. Within the first 2 years, perhaps a third will get some improvement. If you look at longitudinal studies, perhaps up to 30 to 50% may get some improvement over a 10-year period. So a late improvement is not without the realms of possibility, but be realistic with them. I would consider giving some medical options if the MRI scan doesn't show contracture injury, if they're within 12 months of injury, if they're younger patients, and particularly if they've got some preservation of olfactory function. And you may need to give consideration to any conductive components. So here's an example. This was a 39-year-old male athlete. He unfortunately had a nasty head injury despite wearing a helmet. It was a closed head injury. He was observed in hospital, period on ITU. Noticed the loss of taste, actually was olfaction after hospital discharge. He had depression and also personality change, and unfortunately his frontal lobe looked like this, so a pretty impressive sort of trauma that he suffered. And really here you have to be realistic that this is now going to be conservative and supportive management. Okay, so what else can we do for these patients? Smell training is now something that's been looked at in a number of studies, particularly from Thomas Hummel's group. And this simple process of exposing individuals to odours, 4 odours usually, twice a day, just for a few minutes, over a 3-month period, can bring about improvements, albeit subtle. And if you look at the most recent work they did on modified olfactory training, so this was changing the odours every 3 months, you can see here's the control group, here's the classic olfactory training group, and then here's the modified group, and then you see the additional improvement. And this is the TDI score for the sniffing sticks, with 31 being normal, so you can see this group actually coming up into the sort of upper hyposmic range. This should be a patient-led thing, so we give out this information leaflet to patients in the clinic. There's also much information on this on the charitable website of Fifth Sense. Other things to think about really are adaptations in the home and the workplace. If smell is an issue for their work, get them to talk to their managers and their colleagues. Thinking about diet, encourage them ways that they can enhance their diet, enhance true taste perception, texture, hot and cold, spiciness, all those things that they still can perceive. And actually, they can still get some enjoyment from it, and there are ways they can find through this. And the other thing is about their self, so personal hygiene being one, and talking to friends and family about it, sort of really just sort of being open about the problem. As I mentioned, this is now a useful resource for patients. This is our charitable website, and you'll find much information there that patients can go off and read in their own time. So I mentioned briefly about qualitative disorders earlier, so we'll just think about that for a moment. These are common in post-viral groups, post-traumatic groups, but also in the chronic sinusitis groups, and a number of cases that are apparently idiopathic. And these are sort of self-reporting patients from our Fifth Sense member survey. So there are a few things that people can do at home to try themselves. So I usually have this on an information sheet that I hand out in clinic, and they can try this for themselves at home. Obviously, some of these they might want to do, but they're encouraged to try all these things. But one of the key questions that I ask to people with these problems is it the loss of smell that bothers you most, or is it the distortion that bothers you most? Now, usually a lot of the time they'll actually say it's the loss of smell that is the issue, and so I'll take them down the pathway that we talked about already to managing the primary problem. But if it's the qualitative issue that they're really bothered about, then I will still kind of try and sort of consider the quantitative options if they've got a low TDI score. But we can talk about topical therapies, so inducing rhinitis medicamentosa with decongestants, for instance, so you're kind of blocking the sense of smell. But gabapentin is quite useful to ameliorate these qualitative disturbances. I've never done it, but Don Leopold in the States sort of published a series of stripping olfactory epithelium from patients who were so sort of disabled by their parosmia and phantosmia that they wanted rid of the sense of smell in effect. I did actually see someone in clinic the other day who was particularly distressed about their post-traumatic parosmia, and what I did was sort of put some cocaine paste in the olfactory cleft to see if sort of giving them a temporary anaesthesia area was something that they found relieving. It sort of mediated it slightly, but not completely. So we had another talk about medical strategies. So what is there in the future? Well, in terms of prognosis, certainly obviously if they've got CRS, then I think a lot of patients, if they're well managed, can get the sense of smell back, particularly if they haven't had destructive surgery done already. For the post-viral group, at least a third of patients will probably get some spontaneous recovery over a 3-year period. As mentioned already, the post-traumatic group, perhaps in longer-term studies have been shown to get some recovery. With the idiopathic group, I will sort of counsel about the possibility of neurological disease and be realistic about that with them, and just think about the things to look out for, and just talk to their own family doctors about that if they're concerned. Often what they'll ask me is it possible to cure me, and I'll say no, but obviously we can sort of bring about potentially some improvement depending on the cause, but we have to be sort of cognizant of the fact that all senses decline with age, and the elderly patients, this may well be a feature of the aging process. You may have seen this, it was in the news sort of 4 years ago. This was the paralysed man that was able to walk again from grafting of cells from the olfactory bulb into the spine. So often people ask me, well, if you can do it that way, why can't we do it in reverse? I don't have the answer for that, I'm afraid, but I suspect sort of stem cell research may yield some answers for us in the future. There is work that's been done in animal models to consider olfactory bulb grafting in rats. I suspect that's some way off being available for humans. Again, in a mouse model, some work's been done with the Tanacept, which is an anti-TNF blocker, which the rheumatologists use for seeing their patients. So we're going to be doing some work, hopefully next year, actually looking at patients who are receiving this in a rheumatology clinic and getting some idea about olfactory performance in those patients. Olfactory implants, well, we have cochlear implants. I suspect, unfortunately, for the sense of smell, trying to wire these things up to ameliorate that is probably a much more complex undertaking. But there has been some work being done to look at washing out olfactory neurons from a simple nasal wash and analysing DNA and looking at etiology in cases where we don't understand what's happened. And I guess one of the key things we definitely need to work on is, as I mentioned before, the drug trials. So I've done some work previously with sodium citrate, which has given some possible signs of encouragement, but only in a short-term sort of measure. So whether it has a longer-term role, we don't know. Recently, last year, there was a sort of trial published on vitamin A drops, which had quite a promising response in a trial in Thomas Hummel's group. And theophylline definitely needs more work to underpin whether it's a viable option or should be considered a viable option more widely. So in summary, smell may have conductive and sensory neural components, and bear in mind that in some patients there may be a combination of two to work through those. True test is rare in isolation, but do think about considering it if it comes up in the history. Imaging and blood tests really need to be done on a case-by-case basis, so don't order a scan for everybody, don't order blood tests for everybody, but think about the history. Smell testing is key. It aids prognosis, it aids guides treatment, and really it tells you whether or not they truly have a problem and the level of their problem. And there are some things available, so don't let patients be fobbed off, but also they should be realistic about what is available in their individual case. But we need more work on these treatments. So I thought I'd sort of finish with a quote. This is actually from the film Patch Adams. I don't know if you saw that. It was Robin Williams' film a few years ago. He said, "If you treat a disease, you lose, you win. You treat a person, I guarantee you'll win, no matter what the outcome." And I say that for the patients with anosmia, that is definitely the case. If you just give them the time of day, you take them through the history examination, do a smell test, and understand their problem for them, even if you can't actually offer them a specific treatment, they'd appreciate that they've been taken seriously. If you want to read up on this more, there's a couple of articles that we produced a couple of years ago. This is the book on managing smell and taste disorders, which a number of us have contributed to. And if you want to read outside of the immediate clinical area, this is a fantastic read by a lady who was a trainee chef. She was knocked over walking down the street, had a head injury, and she went to great lengths to really understand her problem. She went to Richard Doty's clinic in Philadelphia and really sort of to understand the process of smell and taste problems. And it's really been sort of translated in quite a great way for the lay reader. So it really kind of takes the medical context and puts it into a context that everyone can understand. And in fact, it was actually this book that was read by the founder of our charity, Fifth Sense, who then got into touch with Thomas Hummel because he sort of found a link in there, and Thomas said, "Come and chat to Carl," and that was really the way we got our charity started. This book is a great read about the history of smells and really about the language that is present in other cultures that we are sort of lacking in Western culture. I definitely recommend a read on that. So on that note, I will pass over for any questions.